Hey, we are. Come on, come here. Her name is Arundhati Patil. Arundhati Patil. She is a professor in pediatric neurology in the department in the MRNC medical college. I'll just share her passion. There are some people who work very differently. Niharika, come forward here. They work very differently. Very, very differently. When she comes, we'll tell because she told me her story last time. She's coming now. Come. Dr. M. Patil. So we'll have that. Please love. What was your breakfast? What was there? Dosa. How is dosa? It's good. He serves you hot dosa. Chutney and bhaji is good. Every time the same dosa or different dosa? So it's masala dosa. Supper, when you give supper? For Friday? Tomato omelette? No. Unique snack tomato omelette. Then Mysore dosa? How much is onion dosa? No. No, but one you said tomato omelette. Supper she said the Friday. Huh? Angala. That are different. Mysore dosa will see back. And then about other snacks? Breakfast? I think should be accompanied. No, please come here. Respected Arundhati Madam, my esteemed colleague Dr. M. Patil, and my esteemed friends, 2019 batch. At the outset, we need to get inspired by some of the people around us, and with that, we keep growing, and they become the role model for us. So for me, I think third Sunday she went back. She told what all she does. She brings breakfast for postgraduates from the Department of Paediatrics. Thinking that postgraduates will be bored. That's why I was asking you what type of breakfast you have regularly. So that when now Madam is bringing only 12, now she has to bring 150. She is ready. Then second one, her journey while coming from Arundhati to Vijayapura, we all know we live in a very hot climate. So in that context, she used to bring water initially with glass, then bottle, replaced by can. Now she is bringing gadi. So then she waters. This is we have never heard like this. So this only goes to show that the passion for to live and be a model for others. So and very, very important is very filled with knowledge. So I'm inspired by her. I was also thinking I'm doing a great job. Now I need to revisit my mind. Because bringing water from Gulbarga in pots and gadi, I don't see anybody thinks like that. But she has, by coming en route to that, the most right plant she gives. So that is the which we are surrounded by such great human beings and great doctors. And she also goes to Ilpal and all to reach the unreached. What is very important. Her passion is to reach the unreached. But we were lucky. She was motivated and brought to our department and our institution, Dr. M. Patil. We all know the ever enthusiastic Dr. M. Patil. We all know already. I told you once in the class. There are two people in this campus, selflessly always proud of this mission. One is Dr. Nuchi, and one is Dr. M. Patil. So, and he does everything. He's a good practitioner. He gives a lot of time to his patients. When he comes to institution, he's always at the doors involved in all the activities. And when it matters most, is institution is his priority. Institution is priority. I have seen. So So these are some of the people you also should have to drive these things. See, we live in a world where we see only common people and they are in their own world. But now we should get inspired by such great human beings, and that's how I look at it. And now I'm revisiting my mind in many areas. That's how, as long as you live, you try to this thing, imbibe the quality of somebody else, and you be a model for others. So with this short this thing, I think every third Sunday, yes, madam, you will have to give a call to the madam. So Friday, third Friday, you give a call. She will tell the timing. The timing will come. It is a structured learning, students. Since now we don't have pressure of exit, let's not do very picking learning, because the neurological cases. She has also brought a patient. See, we bring only some WhatsApp messages, but madam has brought patient to show. This only goes to show, and with the bed and all, we put on video. You have to count that pictures. So madam has to explain how does it look and all of that. Okay, so without wasting much of the time, she has to come. A lot of patients are waiting for us after your class. Yes, she will give your number. So regularly, every third Friday in contact. Then madam will give the topic, put in the group. All of you read and come, because these, unless you read and come, it cannot be covered. She's a full-time teacher. There is no question of structure to say, but now she has to tell you where do you stand and what is the journey you have to reach. So with this few remarks, I thank Dr. Patil immensely for getting wonderful 1 week to the institution, so that you're all inspired by that. And madam, I'm very much indebted to you, and I've learned many things from you. I'll join your group, and you'll be our leader. So with these short remarks, I have present in giving a small, there's nothing, they look big box, but I'm sure she will enjoy, and she will send the WhatsApp what is there inside, it will be secret. She will send you and share in the group. Okay, I don't give anything big, you will realize what simple thing can make a human being. So with this, student teachers are made up by the students. I think you come and give those 2 boxes to madam, and of course you keep it in the car. Anushka and Pavitra. You might guess, but when you go home, you want to open and see and send now only, I don't know. That will matter. Always the crowd chooses sleeps in the night, morning, whatever is available, he comes. Right. There you are. And I think now, frequently, yes, she is also coming to Delhi. So, you need to interact with you. Just spend time, 10 minutes with you.
Yes, sir. Sure. A very good morning to all of you. Sorry to ruin your Sunday this way, but I'm sure you will not regret the ruin. First of all, I mean, it's not that I am just reciprocating what sir has told. You're fortunate to have a principal who's already overworked, burdened all week, and yet chooses to, sculpt you children even on a Sunday morning. Believe me, Sundays are the most precious things in life, especially after you are a doctor. So to trade off your Sunday for something like this speaks volumes about the academic interest that your college and your principal has. But I would be failing in my duties if I don't thank M. Patil sir, who is the reason why I'm here. I think almost since the pre-COVID times, sir was offering me a place in his OPD, although a locum place for a day. But then there was COVID, and then I went to UK, and then things got postponed, and finally I'm here. And I think it's all pre-written for Arvind Patil sir to be here. I mean, this is very rare to see a principal sitting in a class of undergraduates. There are hundreds of teachers like me who would be willing to come they're just a phone call away. So I really don't deserve all the appreciation that sir has given. He's just being very, very kind. I'm just one speck of dust. I'm just a little extraordinary like the rest of you. So without much ado, we'll just start about demystifying neurological examination, right? So I'm not going to first restrict myself to this podium and this mic. Is it all right if I come on this side? Yeah. I'm quite high-pitched generally, so I don't need a mic. First thing I want you to understand is, basically before I was giving this talk, I was just wondering what was my state of mind when I was undergraduate. So I just went back to my remote memory and wondered what I would have expected a UG teacher to teach me. And I'm exactly doing that to you today. So like you, I was also sitting at the other end, and though my father was also a pediatrician, my interest in neurology was kindled because of my father's interest in neuroanatomy. So he was a tutor in anatomy before he joined pediatrics, and he used to dissect the human brain for months together. He used to sit and dissect human brain, and then he would come home and tell me, look, and he would talk of all bizarre terminologies, like corpus callosum, geno, valgum, varus, what all, God knows what all, geno of corpus callosum, sphenoid, and all that. I said, are you studying anatomy? Are you studying Greek and Latin? There seem to be more words which are not English. And he said, to understand medicine, fortunately or unfortunately, you need to know the Western Hemisphere a lot. Okay? Why is this important? Because the devil is in the detail. So somebody tells you maple syrup urine disease. God help me. Where are maple syrup? What is maple syrup? I have never tasted one. I have not smelled one. Right? So it is important for you if you want to understand something. All the signs, all the symptoms, they're all derived from the Western culture, from their bakeries, from their gardens, from their flowers, from their creepers, from their people, right? Whereas nobody ever, I know there are some people who will say that there is something called as namaste sign that you see in hyperextensibility, but I know still nobody has written jawar roti sign, okay? Paneer butter masala color. I want you guys to do that, to teach the Western world what it means. So when somebody said it is called steeple sign, I was wondering as an undergraduate looking at what does steeple means. Sometimes we just learn by rote. Oh, what do you see in epiglottitis? What do you see? And you're like, oh, epiglottitis, laryngotracheal bronchitis. In laryngotracheal bronchitis, we see a steeple sign. The examiner is happy, the student is happy, but nobody has a clue what a steeple means. Right? So steeple is the spike above the church. Right? And then somebody said hot cross bun appearance. Oh, what's a hot cross bun? I don't know. I just know that pav bun that we have. It doesn't have any cross over it. Right? And then somebody says ivy sign. Ivy is a creeper which grows over the wall. Somebody said leprechaun. And they are Irish dwarfs. So stuff like this. So we need to really understand their culture before we are able enough to start naming things according to our culture. And there are phenomenal people who are doing that. I don't belong to that category. As I said, I'm still too lowly to even talk about that. So I want you to start loving the neurological examination, because fortunately neurology is like math. Very easy, very simple. If this is there, then this has to be there. Okay, I'm a bit exaggerating that too. I'm trying to advertise my branch. But yes, there is never and never and never and always in medicine. So I cannot say, okay, this has to be there in every case. Unfortunately, it doesn't happen like that, because human body is very unpredictable. It is a conglomerate of organs which don't behave individually. There's no ego in human body. They all function as a team. So when they function as a team, sometimes the results are not the ones that you have in the textbook. Because what would happen is if somebody tells you that, well, there are some things where it has to be there. For example, if somebody tells you there is hemiparesis, then it has to be a weakness of both the upper limbs and lower limbs. But what is not taught is upper limbs will be differentially more involved than the lower limbs, or the lower limbs will be differentially more involved than the upper limb. So if I have a cliche in my mind, some preconceived notions that, oh, these are not involved equally. So is it just monoparesis and this is just weak? Stuff like that. So you need to develop that ability to question and ask questions to your teachers and then search. And now you have Amma, right? Amma is always there. Who is Amma? So you Google Amma, right? So she is there. But make sure you don't learn from stray sites. Okay, don't learn from sites where somebody, somebody who is a very good content creator. That's a new job right now. Some content creator will write something and then you'll start answering that. I've seen that happening. So what is important in medicine is your answers have to be evidence-based and they have to be sourced from good evidences. So when you answer in the exams or when you answer to patients, I'm telling you your exams are the easiest thing on earth. Because what happens is when each patient comes, that is a need, next, viva, practical, everything, we will ask questions out of syllabus. Okay? So what I want you to develop is, not only you understand what the subject is about, but develop the thought process of teaching there. That is the whole idea of this class here. And I told sir that it is impossible to cover CNS examination in one class. Unfortunately, CNS is not the only thing that undergraduates need to learn. So I try to make it as concise as possible. So the CNS examination in pediatrics is by far almost similar to the adult scheme of examination with some changes. Now, pediatrics is not miniature adult medicine. It's not adult divided by 1 by 20 is pediatrics. No. Pediatrics is a distinct specialty in itself. He is a different person himself. He does not mean any gender specific. I'm just referring to the child. So a child is an individual, and the difference between pediatric neurology and adult neurology is pediatric neurology is all about developmental neurology, and adult neurology is more about degenerative neurology. So both of them are antithesis of each other. So there are some modifications that you need to do in pediatric case compared to the adult. You may not be able to stick to the adult scheme of examination. For example, if somebody is going to test pinprick sensation in children, if you do the first thing that is pinprick sensation, or you do it in the order of the scheme, then the child will start crying and they test and hate you. So you have to do the things which are more enjoyable to the child. Of course, this is not your examination, okay? So in your final examination, if you tell me that some weirdo lady came and said like this, he's going to fire you and me both. So you need to stick to your scheme of examination, but in your real life scenarios, you may have to do some things earlier to establish a rapport with the child. For example, you want to check the vision directly by using red balls and then move the red balls and use rattle and then see whether the child is able to hear and talk. Right? Now, the whole idea about how sick or how not sick a child starts with the child walking into the examination room. So that is the first thing you need to develop. I always tell my undergraduates, we all doctors need to have 3 types of sense. One is common sense, second is medical sense, and third is specialty sense. Okay? Common sense is to understand that a particular person is too sick even to be examined in detail and he needs to go immediately to the ICU. So that's called as triage, T-R-I-A-G-E, right? That is the commonest thing that we need to recognize as doctors. Now I'll give you one example about how minutes matter. There are many situations, especially in neurology, where minutes matter. 2 of them, most importantly. One is stroke, okay? And second, non-neurology is anaphylaxis. Within minutes, you need to act within minutes. Anaphylaxis is actually in seconds. If there's anything that you need to know, which every physician needs to know, you do not have to bother about any drug dose, but you need to know at least one drug dose, and that is anaphylaxis. And you need to recognize at least one condition that is anaphylaxis, because it can come unannounced and it can just happen within seconds. By the time the patient is taken from the OPD to the ICU or your emergency room, the child, the person may collapse. Okay, it's that important. So what happens is in the developed world, I'm sure we are on the path to that. Somebody is having a peanut allergy. They're sitting in a restaurant, and they have got a food which is cooked, which does not have peanuts, but there was a vessel in which peanuts were roasted. That has released the allergens, the protein, and then the food was cooked in that vessel without the peanuts, just roasted, and that has caused anaphylaxis and death right there in that restaurant. So if somebody with a known peanut allergy, they carry an adrenaline syringe, a pre-filled adrenaline syringe called as EpiPen with them. Okay, so that's how much important anaphylaxis is for you to recognize. Now, with minutes that I was talking about, there are certain emergencies in neurology where you shouldn't waste time. In pediatric neurology, apart from stroke, of course, in adult, the stroke is much more important because interventions are done there. In pediatrics, it is also important because the child might just decompensate if the stroke is in the brainstem region or stuff like that. And the next thing is epileptic spasms. So this class, I'll just tell you, I'm just orienting you towards certain conditions and then tell you about the scheme of neurological examination. In one or two classes later, I will just make an exclusive video, audio, and picture presentation about signs and symptoms that you see in your textbook, but then you don't know how to elicit them. Okay, you must have heard them, but you have not seen them, right? So I will just make a presentation. The whole class 1 hour is only videos and photographs. Okay, I'll do that later. So now I said going back to using your common sense and seeing whether somebody is. Now look at this lovely girl here sitting in a white dress. She's concentrating. She's engaging herself. She's making eye contact. She's looking at me. She's wondering why she was brought here. If you look at her, at least you know that her Glasgow Coma scale is 15 by 15. This is the common sense that you should develop. You don't need to, there's one example. There's a dad and a son. A dad who belongs to a generation who believes in common sense, and the son who depends on, Google or his, where am I now? What is the weather now? Okay, the stuff like that. So they're both camping somewhere in some remote corner in Himalayas where there are no floods. God bless the people who are affected by floods in Himachal these days. So they're sitting there and then they're both lying down and they're looking at the sky and they're camping there. Remember I said they're camping there. And Dad says, son, what do you see? So the son says, Dad, I can see Andromeda Galaxy. I can see the brightest star there. There's a configuration there. Probably Pythagoras must have thought like this. If I had a Hubble telescope, I would have seen this and all that. And this says, dumbhead. It means the tent over our head is flown off and it can rain. Okay? So what happens is sometimes when we go into the details, we forget the basics. So I see some undergraduates who come and, they are very enthusiastic to show what they know. That's fine. But the thing is, we should not lose. So what is the basic thing when I look at Saundarya? That's her name. She's as beautiful as her name. And she agreed immediately to come here. So Saundarya, ellaru nenige even clap ಮಾಡ್ತಾ ಹೇಳಿ ಬಂದಿದ್ದೆ. Can you stand for us? Okay, now Saundarya stood up. Just watch her. So Saundarya is giving us a lot of information when she's sitting. Saundarya is giving us a lot of information when she's walking. Right? Saundarya also responded to us when we were talking. So we know that she can see, we know that she can hear, we know that she can comprehend, and we know that she can walk. Okay? Right. If she's feeling very shy, okay. So as I'm talking to you, I'll make Saundarya walk with me. Yes. I'll make all those maneuvers after we get the table, but I'm just talking to you. That one, sir, the one like there where she used to like. The thing is, probably, okay. So I can make better. Now watch her sit. She's sitting comfortably. Okay, she's positioning herself properly and she's sitting comfortably. That means she does not have any proximal myopathy. Okay, she climbed the stairs. That also means that she does not have proximal myopathy. Okay. Right. So the first thing is to look at the child, which is an age-dependent observation that we need to make. Can I have your attention back, please, at me? Yeah, I am also beautiful like Saundarya. I deserve another good look from you. And so are you. So is everyone else. So what I'm telling you is, whether it is a newborn baby or an infant, a toddler, who is carried by the patient, the posture of the patient, the comfort level of the patient within the mother's arms, or a child who is walking, or a child who's even wheelchair bound. I'll show you a video of an amazing bright man, in the next presentation. Even when he was sitting in the wheelchair, he had something to say. So these are the things. These now, have you made some mental impressions now? You have, right? So after doing that, you don't really have to touch the patient to get a lot of information. These are the mental impressions that you make for yourself. And then what you can do is, I will say, of course, this is the post-COVID era where we don't want people to shake their hands. But I need to assess something, so I'll say, Soundarya, how are you? Arundhati, madam, what information did I get here? Huh?
Right around this report.
Yes, you can. Let's make it interactive. What information have I got here? She is conscious, she is cooperative, yes. And you can start up and tell, it doesn't matter, we all do mistakes. Nobody's going to laugh if we are wrong. Yes?
She is oriented and she can.
Yes, yes, very good. What else? What else? Anyone else? Yes, I agreed with all of it. I also got some information when she left my hand. I got the information that she is right-handed. Okay? And when she left my hand, after she shook my hand and she left my hand, she relaxed her hand, so I got the information that she does not have myotonia. I'll show you what's myotonia in the video that I will play next time. So this is how your work has to start the moment she walks into the OPD. Just like if you're dating somebody, then the way you're sitting, the dress you've worn, the eye contact that you make, the impression starts right there, right? That's the best way to teach you guys. I always use that example, sir, because knowledge really drives first when you speak about topics close to their heart, isn't it? Right. So I've got this much information. Now let's look at the proper CNS examination. Okay. Everything that we are going to discuss is already, we have talked about most of it. So this one thing that you should always remember is there is a schema of CNS examination like every other system. Okay, I'll just give you some mnemonics to understand or remember those schema of examination. First and foremost is higher mental functions. Okay, so the mnemonic for higher mental functions there are two parts in the higher mental function. One is psyche, do we have a chalk, please? One is psyche and the second is speech. P-S-Y-C-H-E, psyche, and the second is speech. So if you start with the CNS examination, the first part is higher mental functions, and the second, higher mental functions, you have got the psyche, and then you have the speech. CNS is so beautiful. Somebody can speak about psyche for a week. Okay? It's really a travesty of justice, to condense everything to make it understand. Sometimes, you wonder whether you're mono and diarrhea. Okay? But then it's all right as long as you don't have mental constipation. So, psyche, the mnemonic for remembering psyche is A, B, C, D, E, I, M, O. Okay? Don't forget this for the rest of your life. It will stay with you, I promise. So, psyche can be examined under these headings: A, B, C, D, E, I, M, O. A is anybody's guess. A is not anybody's guess. A is appearance. Okay? How does the patient look? Is the patient pained, distressed, angry, irritable, unhappy, happy, playful, chatty, or deluded, not interested in his own world? I've already given you the answers of every disease. Okay? So that's the appearance. So what was the appearance for Soundarya is she appears calm, she is mature, she is not hyperactive, she is engaging, she is making an eye contact, she is conscious, she is oriented. Okay? Definitely she is oriented to time, place, and person. I don't even have to ask that question. Right? So in the exam, pray that you have a child who is older enough. But I'll tell tell you the tricks of examining children who are very young. There are surrogates for examining them. Okay? So they are the tricks of the trade. That's why I will tell you. That's why it's not. Okay? Jokes apart. So appearance is that thing. Suppose the patient is not ambulant and the patient is bed bound, still the appearance counts. How is the person sleeping? Is there dystonia? Is there a lot of crouching like this? Is there a lot of rigidity like this? Is there up gaze? Is there down gaze? Okay? So these are the appearances that you have to see. How is the patient in the bed? Is the patient hugging the bed or the patient is divorced from the bed? Suppose patient has severe contractures, he will be like this over the bed. He is not hugging the bed. Okay? So that is the appearance that is important. Suppose somebody, and this thing applies to all systems. For example, somebody has pleurisy or empyema. Okay? You ask him to move, he will struggle to move this part because this is so painful. When he moves, there is painful. Somebody has pancreatitis, he wants to be like this to relieve that edema. Right? Somebody has spontaneous pneumothorax, how is he? Is gasping for breath. Right? Sudden onset. So, appearance. Second is behavior. How is the behavior? She was very cooperative. Right? She's calm. She does not have any anxiety. She is not throwing tantrums. She is not looking at her parents repeatedly for rescuing her from here. There are many children who do that. Hyperactivity. So again, there's a thin line between pathological hyperactivity and physiological hyperactivity. That will come with experience. You can sense that with experience. Okay? And then consciousness level. What's a consciousness level? So consciousness level, and basically consciousness level can be assessed at point 1 T1 and several timelines later. Generally in neurology, if you for your CNS examination in the exam, the consciousness level scale you can use in children is the ABPU scale: alert, verbal, okay, response to pain and unresponsive. That scale. But worldwide there is one scale to assess consciousness, but that is not useful if it's only done at one point of time, which is the Glasgow Coma scale. Okay, usually used in traumatic brain injuries, but it also can be used in acquired brain injuries of any other cause. And that is very beneficial if it is done at different timelines to know the progression or regression of symptoms. Okay, so one thing that all undergraduates need to remember are certain things which are core competencies. Must know is GCS, normal GCS is 15. Okay, and what is the minimum GCS? Minimum. Highest GCS that anybody can have is 50. Okay, minimum. The least GCS anybody can have. 8 is also an important number in GCS, because if the patient's GCS is less than 8, that is an indication to ventilate that patient if he is not capable of maintaining his airway. Okay, but that's not the minimum GCS. Postgraduates. So what is it? 3. 3 is the minimum GCS. I'm telling you this because many people think, oh, what is the GCS? Let's say it's 0. It's not 0. In GCS, 0 is 3. 3 means it is minimal. Okay? You may be in deep coma, you may be on the verge of impending death also. Right? So that is your consciousness. Next is delusions. Whether the patient is deluded. Delusion, hallucination, illusion. You should know the difference between these two. This is more of psychiatric, but it's also neuropsychiatric. Okay? Now I will give a gift to somebody who will pick up something that I have not told in this class at the end of this class. Okay? I will not give a clue as to what that is. If you are observant, you will pick up something and learn to look beyond what is seen. Looking beyond the obvious is a skill you will develop with time. Whether it is PT or UG, I will not give any clue. I will not tell about whom it is. I know that it is about somebody who is, it is about somebody or somebody related to somebody. That's the end of it. Okay? Right? Okay. So, delusion is creating something which is not there. Okay? Illusion is something is there but it is misinterpretedly seen. Right? And for example, you have your mirage on the tar road. Okay? So that is there. It looks like it is there but it is not there. So you are seeing it as something else. So that is an illusion. So many optical illusions are available. But at the same time, this is I'm talking of the natural phenomena. But pathologically also, seeing something and thinking that it is something else is an illusion, right? And then hallucination. So again, hallucination may be visual, it may be auditory, it may be tactile, it may be cognitive, anything. Okay, I'll not go into details of that. So that is your illusions, hallucinations, illusions, and all that. E is emotion. How is the emotion? Is the patient emotionally labile? Is the patient emotionally stable? Okay, so an emotionally labile patient is like, very in his responses, you can make it out. Like, somebody is like, he's just sitting, suddenly he bursts out into laughter. Suddenly he'll start crying without any provocation. That is important. Laughter also in neurology, we are very psychotic people. Even laughter, we call it as pathological. Can you believe this? I mean, are you out of your mind? Laughter is a nice thing. Why is it pathological? It is pathological when the laughter lacks mirth, M-I-R-T-H. Mirth means joy. So that is called as mirthless laughter. Mirthless laughter means somebody is laughing, but there's no joy in that laughter. So you see that in at least 3-4 conditions. Okay? One, simple and preventable disease. Anyone? Have you heard of mirthless laughter? Have you seen a child with tetanus? Rhizus sardonicus. Sardonic means that there is a smile, but there is no joy in that smile. It is satirical smile. Because that's what there's a Christmas. That's a mirthless smile. Okay, that's tetanus. Second, you see the same thing in Wilson's disease. Okay. Third, you see it in a condition called as gelastic epilepsy, where there's a hypothalamic hematoma and the child laughs. That is a seizure episode. It is not recognized by parents. That laughter is a seizure episode. Okay. And fourth is laughing epilepsy itself, even without a hypothalamic hematoma. Okay. So this is how observant you should be. I started realizing, after going deep into something, my children used to know, don't tell that person is dysmorphic. I was sitting in the railway station and the train was like, what? And we looked at that person is so large. Mama, stop it. The whole world can't be abnormal. I said, they're not abnormal. I'm just telling there is some dysmorphism. So what I'm telling you is you need to recognize them because they're subtle signs. It does not mean somebody is abnormal. It means I've made an observation, but I'm going to take them as a conglomerate and then make a diagnosis. Okay? Then your intelligence. Now, intelligence, ideally, it should be measured with scales, not ruler scale, not that. Bachelor's intelligence scale, a Vineland social maturity scale, different scales, various scale of infant development, all that. But you can take simple parameters like your developmental quotient, what is the developmental quotient of the child, what is the intelligence quotient of the child, PQ, EQ, IQ. You can do that and make a rough thing. For example, suppose you have a 1-year-old child who's just learned to sit, then I would say that the motor age is about 6 months, 6 to 9 months. Okay, so that way you can draw rough parallels in your university examination. Okay, and then you have memory. So memory again, memory can be recent memory or remote memory. Remote memory is something which is 3 to 6 months ago. Recent memory is something which is either the same day or within that week. So how can you assess your patient's memory? Ask them simply, what did you have for breakfast this morning? Okay. Or what did you eat yesterday night? Who were your friends that you were playing with in the school yesterday? Right? And remote memory is something like where did you go for a holiday in summer? Things like that. Okay? So that is your memory. And orientation, I'm sure you all know. Orientation is, what are the 3 things? Oriented to time, place, and person. Okay? So these are the things that you need to record in your psyche component of higher motor functions. I would suggest that, because this is a bit complicated, it looks like that, but it's deceptively complicated. When you are taking any examination, make it a habit to write CLS examination also, if possible. In detail, appearance, looks bright. Behavior, normal. Consciousness, fully conscious. Make like that. So even though the patient is not a CNS, so if you are, that is why you see where you need to upskill yourself. So I was somebody who was very scared of murmurs. I hate auscultating murmurs even to this day. So what I would do is, whatever was my fear, I started facing that fear. Started repeatedly doing cardiac, I used to write cardiac examination also in a non-cardiac case. Why? Because I wanted to overcome that fear of cardiology, or the murmurs rather. Because murmurs are so subjective. We used to write all kinds of things, opening snap, click, mid systolic, ejection systolic, everything. And our cardiologist examiner used to come and say, bullshit, there's nothing of this sort, there's no murmur at all. Or there is a nice murmur and you have not recognized it, or you don't know whether it is at the beginning of first heart sound or the second, it is in the middle, ejection, subjection, God knows what all it was. I never understood that at that point of time. And our cardiologist was very blunt on his face. And he used to say, okay, keep your stethoscope there. You have not heard it in the first 10 seconds, you'll never hear it. Get lost. So it made things even more difficult. So if there's something which is intimidating to you, keep doing that over and over again until it becomes a routine practice for you and it becomes a habit. Okay? And then you have done these aspects of psyche. Speech. Now, speech is very, very intriguing. Again, there are videos on different types of speech that I will show you in the next class. So remember what I'm telling you now so that you can relate to it when in the next class I'll show you those videos. So speech has two components. What are they? Expressive and receptive. Okay? Expressive is motor, receptive is sensory. Right? So I will not go into very many details and overburden you with information. But remember that speech always is visual speech and spoken speech and written speech. Okay? So when somebody shows me a piece of paper in which something is written, I can see that something is written, my vision is good, but I don't understand what it is. So that is word blindness. That is the receptive speech difficulty. Right? That's usually in the frontal area. Suppose somebody tells me something, I can hear some sound, but I'm not able to understand what that person is speaking. Again, that is word deafness. Again, a type of receptive speech defect. Similarly, it is the motor component. Either I have dysarthria or aphasia or dysphasia. Okay? So what is the difference between these at undergraduate level? It's important for you to understand. So speech defects can be because of three parts. One, the brain itself, the master organ. Second, the throat, which is the larynx, the whole voice box. It could be the larynx, it could be the soft palate, it could be the hard palate, whatever it is. Or it could be peripheral articulation defects, the tongue, the lips. Okay? So for that you need to do some assessment. You should know at least 3 syllables to assess speech. One is k, another is p, another is d. Okay? K, p, d. Everybody say k. Where is it coming from? Yes, it's coming from your throat. Okay? K. Okay? Then say t. T. It's coming from your tongue. T for tongue. And then say p. It's coming from your lips. These are the labial sounds. These are the tongue sounds and they are your throat sounds. Now, either there's a defect in the articulation, like I have said, or there is a defect in the quality of. Sure, sir. Thank you so much.
Thank you. Enjoy.
So either there is a defect in the articulation, or there is a problem with the quality of sound, like a nasal sound, right? So articulation means, for example, somebody says her name is. I will not take her name. I don't want her to feel anxious. So Arundhati, and then if there are articulation issues, the person will say Arundhati. Okay, this is stammering, stuttering, right? Somebody may struggle with r. R is again a tongue syllable. Or they will say Arundhati. Okay? And if there is dysarthria, okay? So dysarthria again mostly means articulation defects. So they might say, suppose somebody has, a very large tongue, or somebody has hypoglossal nerve palsy, or stuff like that. And then okay, it comes like this. And suppose there is scanning speech, where you scan the words, like okay, this is scanning speech, right? And suppose there is staccato speech. So somebody says staccato speech, then they will say so it is having a sudden crescendo and then a sudden decrescendo. So that is your staccato speech, explosive speech. So you see that in certain cortical lesions, right? So that's it about your speech. Then this is your higher functions. Next is cranial nerves. Quick recap of cranial nerves. Tell me how many of them are pure sensory, how many of them are pure motor, how many of them are mixed. Are we clear about that? Tell the name, quick, and their function. Olfactory, sensory, motor, mixed. Sensory. Okay. 2. Optic, sensory, motor, mixed. Pure sensory, very good. 3. Oculomotor. Pure motor. 4. Pure motor. 5. Mixed. Okay, very good. 6. Pure motor. 7. Mixed. 8. Sensory. 9. Glossopharyngeal. Mixed. Why that confusion? 10. Mixed. Good. 11. Motor. 12. Very good. A big clap to yourself for writing it and telling it so well. Clap for yourself. So, these cranial nerves is one class in itself. Do you want me to tell any part of cranial nerve which you find it difficult, or you just want me to make it a small gist and tell me? Do you find any part of cranial nerve examination difficult? See, this is the occasion for you to talk uninhibited. Don't think, oh, what will other think? What will that other think? Other person think? No, like just yesterday I was reading something. वो 4 लोग क्या करेंगे? वो 4 लोग मेरी अर्थी पे बोलेंगे गरम-गरम पूरी लेके आना. Nobody is bothered about us. So don't even bother what others are thinking about you. It is better to speak and learn than to be dumb and remain dumb. So is there anything you want me to tell in detail about cranial nerves? Okay, I'll just make a gist and tell you. Olfactory cranial nerve, भूल सकते हो उसको. Okay, generally not much significance. There are some situations where the fracture of the pupil complaint of point or such like that, where there's anosmia. In the COVID time, that was very popular. Anosmia means COVID. Okay, that is all sensationalization of that. And then you have your optic nerve, very important. Optic nerve is the window of the brain. Whatever is happening in the optic nerve, it is representing the brain. So 4 things in optic nerve examination: visual acuity, field of vision, color vision, fundoscopy, and pupillary reflexes. Pupillary reflexes are also a part of your third cranial nerve examination and also optic nerve examination. So visual acuity, field of vision, color vision, fundoscopy, pupils. Very important in your second optic nerve. 3, 4, and 6. What are these? Yes, they are muscles. They are nerves which are supplying the extraocular muscles. So important to recognize each of them. But one thing that you should remember is this 6th cranial nerve thoda sa badmash hai. Okay? What the 6th cranial nerve does is it tries to trick you. It tries to cranial nerve palsy recognition is very important because it is a false localizing sign. It's not a true localizing sign. So what's the function of the sixth cranial nerve? Which muscle does it supply? Lateral rectus, LR6. Okay. So lateral rectus acts in abduction or adduction. It is very important for you to know this concept. So remember this acronym RUB. That thing you remember. The rectus always acts in abducted position. Okay? So in abduction it is the recti which work, and in adduction it is the obliques which work. Right? So when you abduct the eye, for example, I am checking the right eye in abducted position. I am asking the person to look this side. There is inability of that person to abduct that eye towards the right. It struggles and there can be diplopia. That means it is a lateral rectus palsy. That means it could be a false localizing sign. If there is only lateral rectus palsy, of course, nothing has to be interpreted standalone. It has to be as a part of the whole clinical examination. And when you do that, you know that there is raised ICT. So why is the lateral rectus palsy a false localizing sign? Very popular UG question. Anyone? What is the course of lateral rectus muscle? Abducent nerve. I will wind up in 10 minutes because I will need to go back also, and I know some people are getting sleepy because they didn't sleep because TGIS it was yesterday. What is TGIS? Thank God it's Saturday. So today is thank God it's Sunday. Tomorrow is NTIM. No thanking because it's Monday. Okay. So what happens is lateral rectus muscle innervation is by your abducent nerve, and abducent nerve has the longest course in the brain. So whenever there is edema in the brain, it gets swollen and that causes the palsy, which is not a true palsy, right? So you will have a lateral rectus palsy, and that's a false localizing sign that is raised ICT. And then seventh cranial nerve, only two things I want you to remember. Okay. Maybe next class we'll go into every single detail of the steps of examination. Differentiating between upper motor neuron and lower motor neuron facial palsy. So the difference is lower motor neuron facial palsy. What is the problem? Which part of the face is affected? Lower motor neuron palsy. Lower motor neuron means nucleus and below the nucleus. Anywhere for any cranial nerve. Okay. So lower motor neuron facial palsy, one half of the face is totally not working. Right? So one half means there is absence of wrinkling. All of you do this? Wrinkling. Okay. Look at each other's face. You can't look at your own face. Look at each other's face and wrinkle your forehead. Yeah? Okay. So what is happening? You are able to do that. Then next is smile and look at each other. Is it symmetric smile? Is the nasolabial fold seen? Then you don't have a facial palsy. Okay? And next is deviation of angle of mouth. Right? So, and then blow your cheek. Do that as a kid. So you have to do the same thing for the patient also. So lower motor neuron facial palsy is also called as a Bell's palsy. And Bell's palsy is different from Bell's phenomenon. Go and read at home what is Bell's phenomenon. And after this, you have to differentiate how to do upper motor neuron, how to differentiate an upper motor from a lower motor. So upper motor neuron facial palsy, what do you see? Very good. So facial nerve has got bilateral representation in the cortex. So something, the other part covers for it even if there is a palsy. But how do you recognize bilateral facial upper motor neuron facial palsy? One side to both sides. So because both are absent, everything is lost. Okay, upper motor bilateral facial palsy. So I'll leave that for you to read and let me know the next time. I will not spoon with everything. Okay. So that is upper motor neuron. The upper part of the face is spared. Okay, only the lower part of the face is affected. That's how we differentiate upper motor neuron from lower motor neuron. But element facial pulse is more common than upper motor neuron. And then you have your eighth cranial nerve. You do your release and reverse test. You need to know what is the frequency of tuning forks. For which one you will use proprioception vibration, and which frequency you will use your renaissance reverse test. Okay, very important. So that is a basic knowledge that everybody should have. And then you have your ninth cranial nerve, glossopharyngeal. Okay, and you know how to test for glossopharyngeal function. Then vagus, glossopharyngeal and vagus are usually assessed together. Most important thing is the gag reflex. Very, 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 very important reflex to be examined, especially in cases where you have a lot of drooling, you have got a very different quality of sound of voice, in cases like Guillain-Barré syndrome, in cases of diphtheria. Very important to know whether gag reflex is present or not, because the patient needs to be ventilated and not fed orally if there is a palsy of the ninth and tenth cranial nerve. The patient can aspirate and the patient can die. Okay, and then you have your 11th is spinal accessory. Okay, shrug your shoulders, your trapezius, and then 12th cranial nerve is tongue. Okay, this is your cranial nerves. Now motor system, I will not tell anything. I just examine on her. Okay. So motor ನೋಡಿ ನಿಮ್ಮಲ್ಲಿ ನೋಡಿದ್ರೆ ಓಕೆ ಅನ್ಕೊಳ್ಳಿ ನಮ್ಮ ತಿಲ್ಗಾಮ ನೀವೇನು ಮಾಡಬೇಕಾದ್ರೆ ರೆಸ್ಟ್ ಚೆಕ್ ಇಲ್ಲ ಹಂಗೆ ನೋಡ್ತೀವಿ ಆಯ್ತಾ because I examined her undressed and examined her, she's a bit so motor system is look at her posture first, okay, as I'm doing the motor system examination. The last benches are not able to see, you can come this side. Or you're able to see that. Good. Okay. So, still living in the pre-digital world, sir. Oblivious that there is a screen behind. Okay. So, motor system examination, you know what is the motor system examination? Nutrition, bulk, power, reflexes, uptake that we need to see. Nutrition, unfortunately, I cannot address her in a big audience like this, which is against her modesty, so please bear with me. You have to just see how is the nutrition in general of her upper limbs and lower limbs. Is there a lot of wasting, or it appears like, you know, she is reasonably nourished? There are definite parameters for that, but these are some visual inspection that we need to do. And then bulk. So, to see the bulk, you need to take proper measurements from a fixed bony prominence. So, for example, it is the bulk of the arm, then you will take measurements, the same measurement on both sides, which is the largest, measurement in the whole bulk that you have to see. You have to take that, and that will be see how many centimeters it is from the nearest bony prominence. So here you can take the acromion process of the scapula, then you can take the lateral process of the in the elbow, and then you can take the brachioradial, this stylus of the radius. So from here you can take measurements on both sides. Similarly, the anterior superior iliac spine from the patella, from the medial or the lateral malleolus, whatever you want to do, you can take from that the same measurement on both sides to see if there is any asymmetry. And then your tone. Now tone, two things you have to remember. What is tone? How do you define tone? Tone is, yes, you can tell whatever you know. Doesn't matter even if you're wrong. Yes, it is an abnormality of tone, correct? But what is the definition of tone? You're right. It is related only, but what is the definition of tone? Anyone else? Yes.
Tone is the resistance exerted by the muscle against the passive movement.
Very good. Very good. So, tone is the resting state of the muscle, and it is the resistance offered to passive movement. Very good. That's the definition of tone. Now, there are two things that you must know in tone. Suppose there is plasticity or there is rigidity. You have to recognize that first, and similarly, the tone has to be assessed. So, suppose this is plasticity. Remember that spasticity is velocity dependent. Okay, so you have to do it fast. So suppose I have this child now. How did I recognize it is spasticity or rigidity? Look at the posture of her walking and the posture of her leg. Okay? Her leg is not hugging the bed. That means there is some element of spasticity. This is how I've made a visual impression of that. Plus, when she was walking, right? So what I will do is, I will not examine here, I will examine here. So I will do a fast movement like this. Okay, because it's a velocity dependent movement. Can everybody see? Yeah. So if it is spasticity, it's usually described as clasp knife spasticity. You know that Shri, which this showcase we have, urchins on the road. So when they release, there is initial resistance and later give away. So that is what you must keep in your mind when you are doing this. Initial resistance, later give away. This is spasticity. Suppose there is rigidity, there are many types of rigidity. One of them is rigidity, you have to do it slowly, like this. Okay? Spasticity, if you do like this, you will never pick up. Right? So when you do like this, suppose there is resistance throughout the movement, it is called as lead pipe rigidity. Okay? Throughout the movement. Right? Suppose there is resistance in installments like this. The hand will not move like this. I'm just showing you. Then it is called as fog wheel rigidity. You know, like that wheel. When they give the piece in that movie. Have you seen that? There's one wheel, water wheel rotating. That's a fog wheel. Okay, it is like that. So that is the most important rigidities that you need to understand. Now, after I have done the tone examination, then I will look for the power. Now, again, power examination itself will take 1 to 2 hours. So, you have to test power in individual muscles, not even group of muscles and not joints, in individual muscles. And you should know the innervation of those muscles also. Okay. So, that is your power assessments of all the muscles in the body, predominantly diaphragm skeleton. Then next is your reflexes. So I will just demonstrate how to look for reflexes because there is a particular technique of demonstrating that. Okay. So first is I am doing my biceps. Right. Ideally, I should come on the right side of the patient, but because you can't see, I'll come on the left side. So what you have to do is the hand has to be, the upper limb has to be in the next posture. Keep your finger over the cubital fossa, and then it has to, she has actually have to support. I think, is it okay if I can come on that side? I think you can still see. Then put up somewhere. So see, when she's getting up, also you're getting some, put up. This side, yes. She can see, but she has to face me. Yes, good. Can you see? Is it visible? So, I'm going to support her hand on my hand. Okay. Keep my thumb on the like this. Can you see it now? Still can't see? Inga. So put it on the leg. Good. Right. So then I'm going to tap like this. Okay? Can you see this? This is how I'm looking for the biceps jerk. Right? Then in a semi-prone position, I'm looking for the bicep jerk. Then I'm looking for the supinator. Okay? These are the upper limb reflexes. Now lower limb reflexes, she has got unfortunately some very classical signs, good for you but bad for her. Malcolm. How do you look for the knee jerk? Okay? So I am going to support her weight and make her knee hang like this, right? And then tap on her patella. You see that? So this is a generally knee jerk is quite pressing, but in this girl, knee jerk is exaggerated. Okay? Yeah? The same thing here. You see it? When the reflex is so exaggerated, I have to do another manual. What is that? I have to do a clonus. I have to elicit a clonus. Okay? So this is how I elicit ankle clonus. You can also do a patellar clonus, but ankle clonus is quite visible in this child. So I'm supporting, I'm flexing her hip a little, I'm flexing her knee, and then I'm supporting her ankle on my hand, and then I will give a sudden deep breath. Yes. Settle madam, settle madam. ಆರಾಮ ಆಗ್ಬಿಡು. ನೀ ಏನ್ ಮಾಡು, ನಾ ಹಿಂಗ್ ಮಾಡೋದಿಗೆ ಹಿಂಗಿಡಿ, ಹಿಂಗಿಡಿ, ಹಿಂಗಿಡಿ. ಟೈಟ್ ಆಗಿಡಿ. ಟೈಟ್ ಆಗಿ ಹಿಡ್ಕೊ ಹಿಂಗ, ಜೋರಾಗಿ ಅಲ್ಲಿ ಕಟ್ಟಿ, ಹಿಂಗ, ಹಿಂಗ್ ಮಾಡು. So I'm doing a dendritic maneuver, okay, to divert her attention because she's becoming very conscious, right? She is holding it very tight. Loose madam, loose madam, tight hidi, ಇದು tight hidi, ಹಿಂಗಡಿ, ಹಿಂಗಡಿ. ಇನ್ನ ಜೋರಾಗಿ, ಇನ್ನ ಜೋರಾಗಿ. Well sustained clonus now. She hold it very rigid. Madam, I lose madam. She's just very anxious. I will show you a video. I just took a video of her thing. Madam, go to the line. She's just, overwhelmed by the presence here. Otherwise, I just took a video in the OPD, and this was her clonus. So it happens like this in the exam. Because there when you were examining and when the examiner is there, it will disappear. Okay? So I think I am at your end today. In spite of the interesting maneuver, she is not getting relaxed. Okay. Until this loads, I just try once more. If it doesn't, then I can just show it there. Okay? So this is the technique to do your this one. Okay, it will come now. Can you see a bit now? Actually, it's quite well sustained. Okay. Okay. So when you have any reflexes, remember you have to grade reflexes. It is there in your book: 1 plus, 2 plus, 3 plus, 3 minus, 4 plus, and then 5 plus. Okay. 4 plus is the best you can get. So look for the clonus. Look for the patellar clonus also. Okay. This is how you look for the patellar clonus, and then you can do an ankle clonus. Ankle clonus is easier to elicit. Then sensory system, again age dependent. Next is look for superficial reflexes. Superficial reflexes should have been seen first. So look at the conjunctival, corneal, abdominal reflexes. Okay, coming from lateral to medial, these are abdominal reflexes. In males, look for thoracic reflexes, stroke the side of the thigh and look for the thoracic muscle going up. And then most important is look for plantar reflex. When you're looking for plantar, make sure that it is not very sharp. Okay, and then you can use anything, but this will be the back of the hammer. And then go from the lateral side and then reach up to the ball of the toe, but not fully to the. So what is happening here? See what is happening here. Can you see? Can you see? Okay. I'm going up like this, but great toe is upgoing. Okay, that means she's got upper motor neuron signs, right? And most importantly, look for meningeal signs. So meningeal signs may not always be easy to elicit. For the next sign, make sure you hold your hand over the chest and then look for how easily you can move, and then look for Kernig sign, straight leg raising test. Difficult if they have contractures. So she has got contractures here. Okay. Then look for Brudzinski's neck sign and Brudzinski's leg sign. Suppose the person is voluntarily holding the neck a lot, then there is a technique to elicit that. Okay, one day, so suppose she is voluntarily holding her neck, then bring her to the edge of the table and leave her down like this. Okay, if there is rigidity, voluntary rigidity, they won't be able to hold for long. Okay, and then you will get the true rigidity is hold like rigidity, then it will just stay like this. It will not drop down like this. Right? Okay. Thank you. You're such a wonderful girl. So, meningeal signs and gait. Gait can be said at the first or in the motor system examination or in the last. Right? And finally, cerebellar signs. Look for cerebellar signs. There are at least 10 to 12 cerebellar signs. We'll show you in the video when we do that. Very classical case of cerebellar signs is there. I'll show you in that how to look for those cerebellar signs because we are overshooting the time. And the next available opportunity, I will reinforce whatever we have told today through those videos and pictures. Yeah. So this gate, ideally again, can we play that? Because we have undressed her there and it is very clearly seen there. Watch her as she is walking, okay? So I'll play a video. I sent her out because she should not feel shy when I'm showing her like this. So, what is that gate called? What is this gate called? What is happening? My knee is flexed. My knee is flexed. My ankles, the hamstrings are tight. The hip flexors are tight. What is that? Okay, I will show you another gate. Tell me what that is. So basically it is a high stepping gait with the hip flexor tightness. So high stepping gait occurs in the same fashion, but the hip flexor tightness will allow it to lift up In this child also the child is having the same problem, but the hip flexors are tight. Okay. Then what is this gait? What is this? Yeah, penguin. But in humans, what is it called? Called shuffling gait. Okay. And then what is this gait? Huh? It's a cerebellar gait. I'm searching, as if I'm searching for the center of gravity. Okay. He is bending so that he is chasing the center of gravity. Okay. So this is a crouch. What you have seen here is a crouch. What we have? So what is happening is there is tightness of the flexors of the hamstrings and adductors. So that is causing crouch, like this. So that weight which the has to be borne is not being balanced by these tight muscles. This is a classical case of spastic diaplegia. I have not taken the history, but there is something else which is making me think. And that is what I said, if somebody sees beyond obvious, I'm going to take you okay. Even I have not examined. I just came, saw this patient and then brought them here. So, has anybody noticed that? One gift out from the box for that person. Not noticed? Special? Something else? Yes. Amazing. A big hand for his observation. You look at the younger sibling. The younger sibling was holding the hand like this and having a smile squint. Okay? I also just observed now. I did not see them in the open. So this is highly unlikely to be spastic diaplegia secondary to birth asphyxia. Whenever more than one person in the family is affected, okay, you should not think of birth asphyxia even if there is birth asphyxia as the sole etiology. It may be compounding the problem, but if more than one person in the family is affected, it is highly unlikely that it is coincidental. You always have to probe the family history and see. Okay? I think I'll give you a choice of what to pick from. Okay? Right. Now I need to go back to the OPD. For those of you who want my mail, you can collect it from Patil sir. Otherwise, you can send a mail. If you want my number, you can collect it from Patil sir. Or if you have any queries, you can mail me. My mail ID is dr.arundhati@gmail.com. ARUNDHATI. Okay. Any questions? Anything apart from what sir is already teaching you? I'm sure I have not taught anything extra from what is routinely taught. I just was given this podium, so I blabbered. But it's the same thing as every teacher teaches. So nothing new, nothing different. Okay? Done that?
see that? So the way she turned also is important because if it would have been cerebellar ataxia on posterior column, she'll have difficulty when she's turning around. Okay, because that sudden absence of vestibular inputs. Now I'll show you that clonus thing which was there. These are the reflexes. See that? It was just not stopping actually, right? It's still moving. I had to close the video because it would have been a large video and I would be able to send anywhere. It's still, look at my hand, how it is shaking. So this is well sustained clonus, it is more than 6. Okay? And then it is a well sustained clonus. Clear? Okay.
Thank you, ma'am. Like many Indians wait for Pradhan Mantri's Man Ki Baat, will be waiting for your brain Ki Baat every third Sunday, ma'am. Thank you for your enlightening. Madam has to go and see many patients are waiting for her. Thank you. Any questions are there? You can ask me. I can forward to her. I can directly ask Madam also because she is busy. She may not be able to answer all the queries. If I can answer, I will answer. Otherwise, I can forward to Madam. Thank you.
Thank you.